expected and predicted by the model, so your line will be horizontal. If more patients, including, say, a number of high-risk patients that probably would have died but survived, then you perform better than your prediction, and then your curve will start to go above the baseline, as you can see the performance in this particular unit. However, if you don't perform very well, then your curve will start to go down. And if you can see, say here, for a period of probably about 2 or 3 months, this unit that was doing very well start to drop down in performance. However, these graphs are reviewed every month at the monthly audit meetings. So clearly there was an early indication that something was wrong. And you can see then that in the next couple of months, actually performance is starting to pick up again. So it's a much earlier warning sign than the national audit. So there are a lot more outcome measurements that can be used. We can measure morbidity, and in the UK audit, we now measure renal failure, neurological deficit, heart block, prolonged chest drainage, and ECMO. There are other audits you can think of, blood transfusion, readmission. Essentially, there are many, many elements of the patient pathway that can be measured. However, for an audit to be useful and to be trusted, there are a number of requirements. And firstly, the audit has to be accurate. And particularly if you start to measure morbidity, you have to define exactly what is that morbidity. So is a neurological deficit a patient that has a fit after an operation, or is the patient that has a paralyzed leg? Or are we saying that by the time the patient goes home, and if the neurological problem has dissolved, then we do not count it as a neurological complication? And obviously, it is really important to know what is being counted. Also, for the audit, you have to make sure that your data collection is complete. You need to define the interval you're measuring. And then when you do your analysis, you actually have to define what is normal, because we don't expect any unit to have zero mortality. Because if you have zero mortality, you either don't do any operations, or you're not actually willing to take on any patients that have a little bit of a risk. So really important to say what is normal, and then you have to say, okay, what is an outlier, statistically or clinically, and how do I deal with these outliers? So if a unit or a surgeon persistently, say, has a very, very high mortality for one particular operation, yeah, how do I go about that? Do I stop the surgeon operating, or do I retrain this surgeon? Or actually, maybe it isn't a surgeon, but this surgeon always works with the same anesthetist, and actually the problem is there. So it is really important to define that. However, for most audits and for most sort of quality improvement processes, the action on the outlier measurement is actually one of the big things that is not well developed or not well agreed. The other thing actually that's even less developed is to see what do we do with excellence. Obviously, you'd like to celebrate it, yeah, but how can we make sure that other people can learn from excellence so that the whole quality across the program goes up? So improvements are really, really important. But it's also really, really challenging. And you need to have a passion as a shared vision, not just as an individual, but as a whole department or a whole hospital, to continue to make progress and to maintain that progress. Because quite often making progress means you're changing something. And it is always really difficult for us to accommodate change. So whenever you want to change something and you have either the evidence or the vision that that is an important thing to do, this has to be supported by education. It has to be supported by leadership. And it is also then not guaranteed that the improvements will just happen. You stumble, you fall, but ultimately, if it is the right thing to do, then you will get there in the end. Then finally, we've talked about sort of how the medical team works together, how we get the patient through the operative procedure, but we also should think a little bit about the patient. It is really important to appreciate that congenital heart disease is a lifelong condition, and the patient needs to know that. Yeah, yes, you fix the heart, yes, you put the patch in the VSD, yeah, but therefore this patient is still be at risk of endocarditis because he now has a patch in his heart. So it is important to communicate with the patient to make sure the patient understands the heart problem, the patient understands the type of treatment that they've had, and in particular, is this a treatment to solve the problem, or is it a treatment as part of a series of treatment? And in the end, I'm still going to have an abnormal heart. The patient needs to know the lifestyle implications related to the heart condition, but also the patient needs to be encouraged to have a healthy lifestyle. And also, if there are children or if there are plans for children, they need to know whether or not they can pass it on. Also, the medical team needs to have an understanding of the environment of the patient, because it is no good for us either prescribing or recommending treatment if the medication or the access to treatment for the patient is not available in the environment where they normally live. So in conclusion, congenital cardiac surgery involves the management of increasingly complex cardiac conditions. It is an increasingly complex patient pathway, and the management of patients extends over a lifetime. However, with this approach, we've changed the natural history of congenital heart disease, whereby 80% of patients died at 1 year, to a situation where if we repair congenital heart disease, 80% of patients will survive into childhood. But it is only still 80%, and they still will continue to need further interventions, a lot of these patients. So we need to continue to strive to improve outcomes, and teamwork is therefore required more than ever to achieve this. Thank you very much.
Okay, thanks very much, and thanks very much, Karen. The end of your talk kind of leads really into what I'm planning to talk about for the next 15 or 20 minutes or so. I'm aware that we have gone on a little bit now in terms of timing, so I'll try and keep this perhaps slightly briefer than my previous talk. So my plan for the next few minutes is to talk about surgery in adult congenital patients. So I'm just going to talk about briefly talk about reduced stenotomy, pulmonary valve implantation, and some options to avoid long-term anticoagulation in young adults with aortic disease. I won't talk about aortopathies. So the reason that I want to talk about these three aspects is when Karen and I discussed things, we thought it would be appropriate to just also describe a little bit about the multidisciplinary approach and some to do with the thinking behind the way that cardiac surgery or congenital cardiac surgery is approached. And Karen's given an excellent overview on that. And I'm going to focus a little bit on my approach to redo stenotomy for the first few minutes of the talk. So let me share with you a case that I did just in December. She was a 43-year-old lady with an underlying cardiac diagnosis of pulmonary atresia and ventricular septal defect. Initially, she had been palliated with a Waterston shunt, so a shunt between the right pulmonary artery and the ascending aorta, and then she underwent a complete repair as a child, and then as a young adult needed a change of the right ventricular to pulmonary artery conduit, and also had demonstrated some narrowing in her right pulmonary artery, and had that stented. She became increasingly breathless, and now had been shown to have a dilated aorta, which you can see quite clearly on the CT scan that I'm projecting now. So there's her ascending aorta. Also had severe aortic regurgitation, narrowing of the previously placed right ventricular to pulmonary artery conduit, and narrowing of the proximal right pulmonary artery. And if you look carefully, you can see the outline of the stent in this picture here. So she was discussed at our meeting, and we reviewed the images, images reviewed by the radiologist, very much as Karen has described, and she was taken on for replacement of the ascending aorta, replacement of the aortic valve, replacement of the RV to pulmonary artery conduit, and also to address the proximal right pulmonary artery narrowing. So this would be her fourth operation. And what were my thoughts when I took this patient on, and how was I going to plan my operation? So you'll see on the CT scan that the aorta is very, very close to the back of the sternum. There's the sternum there. There's that dilated aorta, very, very close. But it's important to really look at the images very, very carefully, because you'll see that as you pan up and down, and I've given you another snapshot here on the right-hand side of the screen, you can see that one of the sternal wires is really very, very close to the ascending aorta, really just as it becomes the aortic arch. So just here, you can see that the aorta is very, very closely applied to the back of the sternum. So I think it's really of vital importance to have a good look at the preoperative imaging when one's planning one's operation. To my mind, when you are planning complex redos, CT scanning has the best resolution and provides the most useful anatomical information, because it is presented in a way that we all understand in the anatomy. The difference between CT and MRI is that MRI can be presented to you in all sorts of non-anatomical planes. So therefore CT, in a way, has better reference points for the surgeon to understand the anatomy in detail. And to my mind, when I'm approaching a complex redo, I think the proximity of the aorta to the sternum is the most important feature. I think it's very important to try and obtain the previous operation note. This can give you plenty of clues as to how to plan your operation and what you may find inside. So, for example, the things to look out for when you read the operation note, if it is available, is: did the previous surgeon close the pericardium? Or did he place a substernal membrane? Or were there any other clues that will help you when you're doing your dissection? So, for example, were there any adjuncts or shunts applied to arteries that have been subsequently clipped? That will give you an indication of the anatomy as you're trying to work your way through all the scar tissue. It's important to have these sorts of landmarks to help when you're doing your dissection. So that's the sort of the preoperative planning phase, really. But what else? Certainly, if the aorta is close to the sternum, for example, would you consider cannulating peripherally for bypass before opening the sternum? In that case, should you make sure that the femoral vessels are patent as part of the preoperative workup? Will you attempt a sternotomy and just mark the femoral vessels, or will you go on to bypass through the femoral vessels before performing your sternotomy? I think it's important, and Karen alluded to this in her talk when she talked about the safer surgery checklist. So it's important, I think, that you share your concerns at the preoperative briefing, so the entire team is aware of the potential issues with that patient. This gives the team a chance to prepare, perhaps over and above the sort of standard preparation they would make for a case in the operating theatre. It gives them a chance to make sure the team has ordered and actually has enough blood, because if you do enter the heart on re-entry, you will need to give blood usually fairly rapidly. And if the blood is in a blood fridge 20 minutes away at the other end of the hospital, that it will not suffice. And the blood needs to be there in the operating room when the patient is having surgery. If you have the technology, then having a cell saver available for suction of blood is important to try and salvage as much of the patient's own blood as possible. It's important to attach defibrillator pads. When one has entered the sternum, it is quite possible that the heart will go into ventricular fibrillation if it's touched with the diathermy, or there's any other hemodynamic upset. So I think it's important to be able to defibrillate the heart seamlessly and without having to reach under the drapes or trying to open the sternum in a hurry in a situation where there's an incredible amount of scar tissue surrounding the heart. It's important to make sure that the perfusion team are in the operating room at the time of sternotomy, and that they have the relevant cannulae available for peripheral cannulation, and that it's important that you know how those cannulae are used, so that in that kind of dire situation where you've got torrential hemorrhage, you're in a position whereby you can be in control and you can get onto bypass peripherally without worrying about how to insert the cannula. I think it's important that, having ultrasounded the vessels, if you have done so, that you actually mark the locations of the femoral vessels before draping the patient and make sure that the femoral area is exposed, prepared but exposed appropriately, so that, again, if there is a situation where you need to go on bypass quickly, and, for example, the patient is bleeding and they are hypotensive, you are not relying on palpating femoral pulses to locate the femoral artery and femoral vein. So what happens? What happens if you get severe bleeding on re-entry when you're reopening the sternum? The first thing is to try and get an idea of which structure is bleeding. So this is where your preoperative planning will come in extremely important. So you'll know that if you're towards the top of the sternum, that in that situation that I showed you, it's going to be the aorta. If you're further down, it might be the right ventricle. Initially, the plan would be to control the bleeding point with a swab or a digit, etc. It's important to let your anaesthetist know. They need to know that you're in a situation which is potentially difficult, so that they can make the necessary preparations. That might be getting blood up so they can transfuse the blood quickly. It might be preparations to cool the patient down, so it might be getting ice packs so they can cool the brain. And then, once you have informed the team, I think it's important that you start to mobilize the adhesions around the bleeding point while still maintaining control of the bleeding with either a swab or a digit. Because trying to suture a structure under tension will result in tearing of the tissues, and that could make the situation far worse. You need to consider using plegiative sutures, and if you can't gain control, the next step, I think, is to pack with swabs or temporarily close the sternum, and one can use towel clips to do this, to bring the sternal edges together, and then use the cell saver to scavenge any blood that's being shed, and then make one's preparations for peripheral cannulation. And because you have planned all these things in advance, it hopefully won't take you too long to get into a controlled situation. Once you're on bypass, you should consider cooling the patient to enable periods of low flow, so you can repair whichever structure has been breached. But of course, when you cool a patient, especially adult patients, not so much pediatric patients, but especially adult patients, you need to watch out for ventricular fibrillation. Right, so that's my thoughts on reduced sternotomy. Then I'll go on to something which is very common in our practice in the UK, and that is pulmonary valve implantation for patients that have had repairs of tetralogy of Fallot as children. So you'll know that the repair of tetralogy of Fallot comprises essentially of three components, and that is resection of muscle within the right ventricular outflow tract, and so to deal with the right ventricular hypertrophy. Usually that's in the infundibulum or the subpulmonary valve region, to close the ventricular septal defect, and then also to treat valvar or supravalvar pulmonary stenosis. Now that may either be with a patch that extends across the annulus of the pulmonary valve and therefore renders the pulmonary valve incompetent, or if the valve annulus is adequately sized, by using a valve sparing technique where one may be able to patch above and below the annulus to try and ensure that the right ventricular outflow tract is of a good size. So if the patient has undergone a tetralogy of Fallot repair with a transannular patch and they no longer have a pulmonary valve, they will be subject to chronic pulmonary regurgitation. And over time, they may present with symptoms which will chiefly be exercise intolerance. So it is important to examine the imaging carefully. And what that will probably show is progressive dilatation of the right ventricle, potential for tricuspid regurgitation, and both of those things can be seen on echocardiography. But important is to start to think about other imaging modalities such as MRI scanning, and look for evidence of increased right ventricular volumes on that scan, and see if they reach a surgical threshold. So that threshold currently stands at somewhere between 140 and 160 milliliters per meter squared. So once the patient with chronic pulmonary regurgitation has right ventricular volumes of over 140 milliliters per meter squared, that would suggest that their right ventricle is severely dilated and they should be considered for pulmonary valve implantation. I think it's also important to think about physiological testing. So even if the patient is asymptomatic and there is evidence of right ventricular dilatation, it is not a catch-all. And sometimes it's important to demonstrate evidence of objective evidence of decreased exercise capacity on a cardiopulmonary exercise test. So with all that information in mind, you can then take your patient to the operating theatre with a view to doing a pulmonary valve implant. How might we undertake this? So reduced sternotomy with all the principles that I have just outlined, really. And then on to cardiopulmonary bypass, having dissected out all the relevant structures, bicaval cannulation, and then my approach is to cross-clamp the aorta and give cardioplegia and arrest the heart. In terms of the prostheses that one would normally implant, the suggestion is to implant a prosthesis which is at least 25 millimeters or above. We routinely use bioprostheses. So I would routinely use a Perimount or a Hancock prosthesis. You will see that in the picture here, what I've got here is actually a mechanical prosthesis. This is very unusual to see a mechanical prosthesis placed in the pulmonary position. The reason for implanting a large prosthesis, apart from to make sure that the hemodynamics are good, is that ultimately, if there is a problem, with this prosthesis in sort of 10 or 15 years' time, and the natural history is for these bioprostheses to become narrowed because of leaflet degeneration, the patients can then be referred to an interventional cardiologist for sort of valve-in-valve implantation, so they can still maintain a non-regurgitant right ventricular outflow tract with a second device within your surgically placed valve ring. In order to implant a 25 millimeter or above bioprosthesis, it's usually necessary to augment the infundibulum and main pulmonary artery with a patch, usually of bovine pericardium, which we can just obtain off the shelf. So what are the sort of benefits? Well, once a pulmonary valve has been placed, the RV volume should start to reduce, and their symptoms and New York Heart Association functional class should also improve, and they should also show some improvement of left ventricular function. However, it is not without its costs. So the operative risk is relatively low, somewhere between 0.9 and 4%. 4% is quite high, but 0.9% I think is reasonable. But this is, again, it is it is a re-intervention, and that carries its own risk. There is also an increased risk of endocarditis with a prosthetically implanted valve. What about the things that it doesn't achieve? So it doesn't really have an effect on peak exercise capacity. It doesn't seem to improve right ventricular ejection fraction, and it doesn't really obviate from the risks of pregnancy. And uncertain and not really sorted out are the risk of arrhythmia, the risk of heart failure, sudden death, and the necessity and timing of further intervention on the right ventricular outflow tract. So plenty of questions to be answered still. On my third topic, which is aortic valve replacement or repair in young adults. And the reason I'd like to talk about this is that young adults have a variety of aortic, or can have a variety of aortic problems, but a lifelong use of warfarin is not without its problems, and therefore we need to think about other solutions apart from mechanical valve replacement. So the operation that comes to mind immediately in terms of providing in inverted commas, a living valve replacement is the Ross procedure, which I'm sure you will all be familiar with. But in essence, it is replacement of the aortic valve with the pulmonary valve. The operation involves harvesting the pulmonary autograft. So the pulmonary valve is taken off the right ventricle on its muscular skirt, the infundibulum, with a short segment of pulmonary artery. And then the aortic valve the diseased aortic valve is excised and can be replaced with that pulmonary autograft. But in order to to do this, one needs to excuse me for a second. One needs to excise or mobilize the coronary buttons so they can be reimplanted onto the neo-aortic root. The valve can be implanted in a subcoronary position or included within the aortic root, or implanted by excising the remainder of the aortic root and implanted as a free root. Okay, the coronaries will then need to be reimplanted, and the continuity between the right ventricle and the pulmonary artery will be restored using a pulmonary homograft. So that procedure is well described. It was described by Donald Ross in the 1960s, and it has fallen in and out of favor over the years, but it is an important operation in the congenital surgeon's armamentarium, as I said, because it allows for growth when mechanical and biological prostheses do not. So what about the latest outcomes after the Ross procedure? Well, if you look at the German Ross registry, which is, they've recently published 25-year results in the Journal of American College of Cardiology, and it shows really that the survival in the patients which have had the Ross operation is really excellent compared to a general population. So the survival following the Ross procedure really is very, very good, and the risk of death is actually very, very low. So if a Ross performed by a surgeon who understands the operation and knows the operation and performs a good operation, is actually a very durable procedure with good outcomes overall. But if one can't do a Ross, what can we do? Or if one needs to, maybe if there's a more complex problem where the aortic root needs to be enlarged, well, our options really are to enlarge the aortic root in three directions, either through the back of the aortic root with a Menugian or a Nix, or anteriorly through a Kono. Now, the Nix and Menugian operations will allow a minimum amount of root enlargement, whereas a Kono, because of the way that the root is enlarged, will allow for much more enlargement of the aortic root. So if you've got a really small aortic root, the operation that you want to consider is a Kono root enlargement, because when you do that, you are enlarging the left ventricular outflow tract into the right ventricular outflow tract, and then you can then enlarge the right ventricular outflow tract separately with either a patch or a conduit. So the amount of enlargement you can achieve is large compared to the Nix or Menugian approaches. When you combine this with the Ross operation, you are able to enlarge a small aortic root towards the right ventricular outflow tract. You can see this diagram shows it beautifully because the two outflow tracts are next to each other, and your incision to enlarge the left ventricular outflow tract is through the septum, and therefore enlarging into the right ventricular outflow tract. So the autograft has been excised, the left ventricular outflow tract has been prepared, the left ventricular outflow tract is enlarged, and then the autograft is implanted, often using the muscular skirt that you have excised alongside the pulmonary valve to reconstruct the ventricular septum in this region here. And then one would reimplant the coronaries into the newly placed autograft, and then restore right ventricular to pulmonary artery continuity, again using a homograft. How about repair of the aortic valve? Let me share with you another case that I've operated on recently. This is an 18-year-old male who initially presented to his local hospital with epistaxis, general malaise, and sudden breathlessness. So from being a young, fit teenager, he was suddenly breathless generally unwell and presented with nosebleeds and possible hemoptysis. He was found to have Wegener's granulomatosis, but from the cardiac point of view, he was found to have acute aortic and mitral regurgitation on the transesophageal echocardiogram, which demonstrated perforations in the right coronary cusp of the aortic valve and also in the anterior leaflet of the mitral valve. And because of this, he demonstrated left ventricular dilatation, and he was referred and accepted for surgery. So I went into surgery with a view to trying to preserve both his aortic and mitral valves, because the underlying condition of Wegener's granulomatosis would be a condition that is lifelong and presents a significant bleeding risk, and therefore the options of mechanical prosthesis and warfarin were non-desirable, and also the option of biological prostheses was non-desirable because they would not be durable. So we went in with a view to trying to repair his aortic and mitral valves. So this is a picture of the right coronary cusp of his aortic valve at surgery, and you can see a large perforation within the right coronary cusp. And my first attempt was to try and repair this using a patch of autologous pericardium. So a fresh piece of pericardium was taken, and an attempt was made to repair the perforation within the right coronary cusp of the aortic valve by attaching this patch with 7-O-Proline. However, the problem then arose that when we looked at the repair, it seemed that the right coronary cusp seemed shortened compared to the left coronary cusp and the non-coronary cusp. Now, that could be part of the surgical repair, in that we had to take up some tissue in the valve leaflet in order to patch close the hole, or it could be that the disease process itself had led to shortening of that leaflet. So in order to try and test that, I closed the aorta and then ran some cardioplegia into the aortic root and found that actually the aortic valve was still regurgitant. So what were my options at this stage? Well, I could have replaced the valve and put in a mechanical valve, but I really was loath to do this because of all the potential problems with warfarin. And so we decided that a single cusp Ozaki type repair using pericardium would be our preferred option, and that's what we have done here. So we've used a piece of pericardium. This has been fixed in glutaraldehyde for 1 minute and then washed for 6 minutes, and it's been cut according to a template which has been designed by the surgeon that has invented the procedure, and the plan is to sort of neocuspidize the aortic valve. And the usual way to do it is to actually replace all 3 aortic valve cusps by sizing and then using fixed pericardium to cut out leaflets according to a template, and then suture these in to the aortic annulus to recreate an aortic valve from autologous pericardium. So we use this technique to replace one cusp of this chap's aortic valve. And just going back to this picture, this is what we achieved. And then we closed the aorta and came off bypass, and I'm pleased to say that there was only trivial regurgitation at the end. The mitral valve, incidentally, was repaired through the aortic annulus because I was able to access and patch the anterior leaflet of the mitral valve. So in the situation where anticoagulation is a potential hazard or a problem, there are options available to deal with aortic valve disease in young adults. And this is a diagram of the Ozaki procedure as it's finished, with the 3 cusps in place, having replaced the disease cusps of the aortic valve. Okay, so I'm happy to again take any questions on the chat, but that ends this session. Thanks very much indeed.
Thank you, Shafi and Karen, for a wonderful whistle-stop tour through pediatric cardiac surgery, starting with neonatal surgery, finishing off with adult congenital. That brings us to the end of day 1 of the virtual SCTS Ismailia Masterclass. May I get Mr. Moojani to give you a flavor of what awaits you tomorrow before we wrap it up today? I know it is quite late in Egypt at this point in time. Naren.
Thank you, Sri. I'll just bring up the program for tomorrow. If you just bear with me, I'll share my screen. And I hope you can all see that. So I hope you've, as Sri said, I hope you've enjoyed today. We've given you a great overview of not only thoracic surgery and congenital cardiac surgery, but tomorrow we're going to be moving on to both cardiac surgery and cardiothoracic transplantation. So tomorrow we've got great faculty, some colleagues from Papworth Hospital in Cambridge, but also some senior cardiac surgeons from London that will give you a great overview of the basics of cardiac surgery, and then some operative tips and tricks on how to perform the different procedures. And then towards the end of the day, we'll have some insights into cardiothoracic transplantation from, again, one of my colleagues from Royal Papworth Hospital, David Jenkins, and also Meninda Calcutt, who gave a presentation today. So I really hope you get a good evening's rest today, and it's a big program again tomorrow, and we look forward to giving you some insights into both cardiac and cardiothoracic transplantation. So please, come with your enthusiasm and lots of questions, and we hope to fill you with some wise words of wisdom. So thank you, Sri.
Thank you all. Have a good evening. And I take this opportunity once again to thank my co-course directors and a lovely and enthusiastic faculty. Thank you. Good night.